Good morning. Welcome. My name is Diane Hopp. I have the privilege of serving as the president here at UPMC Children's Hospital. And I'm ever so pleased to be here today because it is a special day here at Children's Hospital. We're celebrating National Patient Safety Week. And for all of us who have been touched by healthcare organizations, who live and breathe healthcare organizations every day and have given their lives to healthcare organizations such as our hospital here and all of our outlying areas, I want to say thank you. This week to me is about pausing, not only celebrating our accomplishments as it relates to patient safety, because we've really come a long way over the past 2 decades, but it's also about thinking about the future and how every single one of us can impact not only patient safety, but employee safety and well-being as well. So for that, I thank all of you. I'm here today to introduce to you, and before I do that, I want to say a special thank you to our quality safety team. We have many of them here in the room today, some of them online, but please give them a round of applause. And thank each of you for holding us accountable and helping to elevate ourselves here as we strive very hard for zero harm in our patients as well as our employees. My most important message here is a very warm welcome and an introduction for someone very special and a family that has been partnering with us for many, many years. I'm pleased to introduce to you today Michelle Christensen. And Michelle is here today with her daughter, Ari. I want to give a special welcome because online virtually we have many people, but we also have Father Dan Christensen and I believe Maddie as well online. I want to thank this family. This is a family who suffered a tragedy, and Michelle will tell us a little bit more about the tragedy that they suffered, but they have been able to transform this tragedy into something real, into something that has impacted all of us. Their passion, their energy, and what they believe in, that if they can save, as Michelle just said to me 2 minutes ago, if this lecture today can save one life, they've done their job. So we thank you for your continued passion, your support to Children's Hospital, and all that you have helped us to learn over the years. Very special welcome. I'll invite Michelle up to the podium. Thank you.
Hi, good morning. This is my daughter Isabel and some family and some photos of family, also with medical staff, because those were her friends and family. For those of you that don't know me, my name is Michelle Christensen. I'm the proud mom of 3 incredible, wonderful daughters, Maddie, Izzy, and Ari. It is my middle daughter, Isabel, who brings us here today. Izzy packed more into her 10 and a half years than many people did in a lifetime. She was spunky, feisty, smart, and deeply compassionate. She loved Tinkerbell, she adored the Annie musical, and believed with her whole heart that you're never fully dressed without a smile. And for anybody that knew her in this hospital, knew that she always had Annie on in the hospital. She had pigtails that bounced when she walked, and she would scrunch up her nose when she was being stubborn, which was quite often to the medical staff. And she was very clear about one important fact. She was never just 6, she was 6.5. That half mattered to her because Izzy understood something most of us forget. Every moment counts. Isabel was born with pseudoobstruction and a mitochondrial disorder. Her medical history was long, layered, and very complicated. As her health declined, her only hope was for a transplant. At 6 years old, she received a stomach, liver, small bowel, pancreas, and duodenum transplant. And 2 years later, she received a kidney transplant. She was, without question, a complex patient. But she was more than just a complex patient. She was a complex medical case. And she was my child and a beloved part of the family. When you care for frequent flyer patients long enough, familiarity sets in. You know their history, you know their routines, you know their families, and they become one of the fabrics of the unit. But their complexity requires vigilancy every single time. On August 11th, 2008, Isabel came to the hospital for what felt like a normal routine, a blood transfusion and IV potassium. In the past, when she received potassium, she was placed on the cardiac monitor. That day, when I asked, I was told it no longer was necessary unless she was in the ICU. Izzy had fallen asleep when she began gasping. At first, we thought it was just a sigh. Then she did it again. We couldn't wake her. A code was called and all my world collapsed around me. CPR was started immediately. Her team, who loved her, worked desperately to save her. During the code, her potassium came back critically high, despite being low earlier in the morning. In time, it was determined that Isabel had received 10 times the intended concentration of IV potassium. Yes, you heard me right, 10 times. The medication had been ordered properly. The correct IV label was on the bag, reflecting a normal dose, but it had been mixed wrong in pharmacy with the wrong concentration. And my 10-and-a-half-year-old daughter died. Today, as you talk about complex patients and safety, I want to remind you about complex patients like Isabel. They live at the intersection of many moving parts, multiple specialists, multiple medications, multiple transitions, multiple hands-off, and multiple assumptions. Familiarity can create comfort, but it also can create risk. When you have a frequent flyer, it can feel routine being with them. But for that family, it is never routine. For that patient, it is their one life. If something feels routine, pause, take a break. If a parent asks a question, lean in and listen. If something doesn't sound right, look right, speak up. Even if you think you're sure, always double check. Because what you're protecting is not just an air. You're protecting birthday candles that will never be blown out, graduations that will never be celebrated, wedding dresses that will never be chosen, babies that will never be held, everyday moments that can never be replaced. It's been many years since Izzy died. The pain has not disappeared. Our grief continues, and our family still lives with an Izzy-sized hole. But we also live with her legacy. This conference exists because of her. Safety changes were implemented because of her. Conversations like today happen because of her. Just culture was started because of her. Near risk misses and catches started because of her. And that matters. Isabel believed in miracles. She believed in goodness. She believed in people. I believe that honoring complex patients means seeing them not as problems to manage, but as lives to protect. Thank you for the work that you do. Thank you for continuing to learn. And thank you for remembering my daughter. Isabel Rose Christensen mattered. Her life mattered. And what you do with her story matters today. Thank you.
Thank you, Michelle, for joining us today, as you have for every year in the since this event occurred. We appreciate all of your support. I'm very grateful for you and your family. Thank you, Ari, for joining us as well today, and to Dan and Maddie who are online, and so many others. And thank you to all of you who are here today. We are very grateful for the support that you have shown us and continue to show us. It is my pleasure to introduce our speaker for this morning, Dr. Michelle Watkinson. Dr. Watkinson serves as an assistant professor of pediatrics here at UPMC, Children's Hospital of Pittsburgh. She started out her medical training at the University of Wisconsin School of Medicine and Public Health, and also completed her MPH from Emory University in Atlanta. After that, we were very fortunate to get her here at UPMC Children's. She came here for her residency, and she completed her residency in the Pediatric Advocacy, Leadership, and Service, or PALS track, as we refer to it. We were fortunate to keep her here after that. She served as a chief resident, and we were fortunate again to keep her and have her join our faculty. And she joined our faculty with a joint appointment in the divisions of palliative medicine and supportive care, as well as general academic pediatrics. Dr. Watkinson recently completed a graduate certificate in pediatric palliative care through the University of Washington. Her clinical, research, and educational interests focus on children with medical complexity, very, very fitting for our conversation today. And she launched an inpatient complex care consult service in 2024 here at UPMC Children's. So very grateful for Dr. Watkinson joining us today and sharing her expertise and all the work that she and her colleagues are leading to help us to further improve the care of our patients with medical complexity. Michelle?
Good morning, everyone, and thanks, Dr. Buchert, for that introduction. I am honored to be here, and it's humble to be in a room full of people who trained me, and a little bit intimidating. But today I am excited to be talking about our inpatient complex care service that I started in 2024 and how we can approach new service lines and programs really as a patient safety measure. I want to echo the thanks to the Christensen family. Thank you so much for sharing about Isabel today, and sharing about her life and her tragic death. And I'm so sorry that she's not here. As far as disclosures and conflicts of interest, I have none to report. Today, I'm going to talk about background on the care of children with medical complexity, who I'll refer to as CMC for the rest of this talk. Why are CMC at higher risk of safety errors, and particularly during transitions of care being a particularly high-risk time? The role of complex care programs in safety for these patients, and then our model at Children's, the results and impact we're having, and next steps. So Michelle Christensen just set this up so beautifully, but before I get into technical speak, I want to share a picture of a child who is so similar to many we care for in complex care. These are such a special group of children that we have a privilege to care for, and I don't want us to lose the humanity of them as I talk about the definitions and data. As we think about a child like this, think about all the specialists that care for this child. So he has a trach, so ENT manages his trach. He is on a ventilator. Pulmonology manages his ventilator, his airway clearance, any other respiratory symptoms he has. GI manages his feeds and constipation and dysmotility. If he has a GJ tube, interventional radiology manages his GJ tube. Physical medicine and rehab helps with his durable medical equipment and tone management. Neurology manages his seizures. Ophthalmology probably sees him for cortical visual impairment. Maybe he has a vagal nerve stimulator and he follows with neurosurgery to manage that, and probably many, many more. But who is looking at the whole picture for this patient? And think about how overwhelming that is for the patient and the family to navigate the system. How many of you have cared for a patient like this? Right, every single person in this room. And I want you to keep a patient in mind, whether that's Isabel or another patient that you've cared for, as we go through this talk. So who are children with medical complexity, or CMC? They're a complex group, and even coming up with a definition is challenging, but the most widely accepted conceptualization of CMC comes from Cohen et al. Article published in 2011 in Pediatrics, and they really conceptualized CMC as kids at the intersection of having complex chronic health problems, severe functional limitations, substantial service needs, and high healthcare use. They often are associated with technology dependence, medical fragility. As I was preparing for this talk, I found another recent article that had a new consensus-based definition that took all different health professionals that care for these kids to really narrow down what the criteria are, and they narrowed it down to 39 criteria, which really highlights that this is a complex group and it is difficult to define them. As such, the numbers of them vary because if you have competing definitions, it is challenging, but the best guesses are that CMC account for 1 to 5% of children in the US. What is not disputed is that this population is growing. With healthcare advances, with technology advances, particularly in neonatology, kids are surviving from earlier gestational ages and with more complex conditions than ever before. In a large study looking at data from the Agency for Healthcare Research and Quality's Kids Inpatient Database, they found that CMC account for nearly 17% of hospital discharges and 45% of hospital charges between 2000 and 2022. And this graph here is looking at the proportion of hospital bed days, so not discharge, but also accounts for length of stay as well, and by number of complex chronic conditions, or CCCs as it's abbreviated here. So the bottom orange bar is for kids with 1 CCC, the middle yellow bar is kids with 2 CCCs, and the top grayish bar is those with 3 or more, which is the best appropriation of CMC that they thought in this study. And as you can see, that proportion of admissions has dramatically increased over the last 2 decades, now making up more than 10% of hospital bed days. They also looked at what have been the trends in which type of complex chronic conditions kids are admitted with over that same time period. So sorry for the busy graph, but I want to highlight a few of these lines. So the top line by the right side with the black squares, that's technology dependence. Neurologic and neuromuscular disease is in the red circles, and gastroenterologic complex chronic conditions are in the orange triangles. Those are all patients that largely are followed by complex care, and you can see the trends over time have been increasing. This contrasts with transplant patients who are certainly complex, but have remained, they're the bottom blue squares, and their proportion of hospital bed days have really stayed the same over the last couple of decades. So why are CMC at higher risk of patient safety errors? There's a number of reasons, as Michelle alluded to. They are on a lot of medications. All the residents in the room who do their med recs know that there are a lot of medications managed by a lot of different providers who may have similar sounding names. They may have varying concentrations depending on where it's compounded at home. And they see specialists certainly within our institution, and many times they follow with a certain specialist at another institution as well. Their care is inherently complex, and it's not simple to communicate what is going on in their care. There's frequent transitions, which we'll talk about further, between teams and settings. They rely on technology, which is incredible and helps keep these kids alive and thriving, but also can set up opportunities for errors. And family are caregivers, and I certainly do not want to blame families for medical errors, but we rely on our patients' families to provide such a high level of care, honestly, like ICU nurse level care, a lot of times in their home. And these are largely not medical professionals. And sometimes I've certainly found myself assuming that they know things that it's not reasonable to assume that they know. But they do such a wonderful job that can happen at times. The data really bears out that these kids are at higher risk of safety errors. So children with chronic conditions had a medical error rate of 5.3 per 100 hospital discharges compared to 1.3 per 100 for healthy children. The odds of medical errors increase with each chronic condition from an odds ratio of 1.4 with 1 up to an odds ratio of 1.6 for those with 3 or more chronic conditions. Another study looked at, they actually completed structured interviews of caregivers of children with medical complexity on discharge from the hospital to assess their understanding of medication regimens. And they found that almost 80% had at least one medication misunderstanding at hospital discharge, really highlighting that we're not doing a great job of communicating why we're doing things. And they estimated that nearly a third of those medication misunderstandings put them at risk for potential harm. So transitions of care are particularly high risk. This kind of highlights where our patients move throughout the hospital and healthcare system. Many of these arrows are bidirectional, they can bounce around, and each one of these has a different team, maybe losing someone that has a big picture view of what's going on with this child. I also want to point out that for simplicity, I just put home. Home is not a one location transition. These kids go to schools where they also have nurses caring for them. They likely hopefully have private duty nursing involved, potentially with multiple agencies going through shift change. Their care is constantly in transition. This places a large burden on parents to provide information to the teams that's not always readily available in a very busy chart, and on the medical teams to dig through massive charts of information. Children who are newly technology dependent are particularly high risk, and this is where these transitions have been best studied. So particularly in discharge from the NICU, the highest risk of readmission for any infant that was in the NICU for greater than 14 days, the highest risk of readmission within 30 days was for two groups, those with technology dependence of some sort and those with public insurance. There's also a lot of overlap there because all of our CMC qualify for public insurance through the Medicaid waiver. So kind of gives them a double whammy of risk factors there. 50% of those readmissions occur within 12 days of discharge. So that period when they're first going home is incredibly high risk. And I've seen this where families don't know who is supposed to be managing different things. They don't know who to call. They've been in the NICU or the PICU and then the floor and then CHRU. And from their perspective, understandably so, who's managing things? The hospital. They don't know who to call when that transition happens. The technology type also affects how likely they are to be readmitted, with shunted hydrocephalus being the highest risk, followed by gastrostomy and tracheostomy. Looking at not looking at NICU admissions or discharges, but for kids that had a G-tube placed outside of the NICU, when they were discharged, 8.6 of them ended up in the emergency room with a G-tube related issue within 30 days, and nearly 4% of them were readmitted with G-tube related issues. Complex care programs are really uniquely positioned to bridge these transitions, both within the inpatient setting and to the outpatient setting and within the outpatient setting as well. As this population of patients has grown, so have complex care programs. Basically all major children's hospitals and many smaller children's hospitals have complex care clinics now across the country. There are various practice models. People often say on the complex care listservs, you have seen one complex care program and you've seen one complex care program because the model really varies based on the needs of a community and a hospital. So the three main types are primary care centered models, where the complex care clinic serves as the patient-centered medical home, and sometimes that includes the healthy siblings as well. There's consultative or co-management models where complex care supports the primary teams both in the inpatient and or outpatient settings. And then there's episode-based models. So some institutions have admitting complex care teams, but they may not follow them when they get discharged. So what does our program look like here? We call ourselves C3, the Complex Care Clinic, and we are primarily an outpatient co-management program. We used to serve in the primary care role, and we have transitioned away from that over the last couple of years. Complex care is inherently interdisciplinary, and anytime I talk to a family or another provider about complex care, I always try to highlight this because sure, we as providers have a little bit more experience caring for kids with medical complexity. We're more comfortable managing feeds, et cetera. But really the special sauce is the amount of support we have behind us and people who have equal experience in caring for kids with medical complexity, that families can call a nurse and get someone who is very comfortable counseling them on what to do with their G-tube feeds when they're sick. So in addition to our 6 physicians and 1 nurse practitioner, we have 4 nurses, 1 nurse care manager, 2 social workers, clinical pharmacists, a dietitian, and administrative assistants that are all key to providing excellent care for this patient population. And then as I'll talk about more, we started an inpatient consult service in 2024. So what do families think about our role in their care? We are lucky to have Justin Yu, who clinically practices pediatric palliative care, but his research focuses on CMC and their caregivers specifically. And he is doing a longitudinal study of children enrolled in our clinic and their families. And he was generous enough to share some of his baseline data, which is extensive. And I'm sure at some point he will be in a venue like this sharing that with you all. But I just wanted to highlight families' perceptions of our role in their care. So more than 80% said yes, definitely, and nearly all said yes, somewhat, or yes, definitely to the following questions. Does complex care know the important information about your child's health and care needs? Do they seem informed and up to date about the care your child got from other providers as well? Really keeping that big picture in mind. And do they support your decisions about what is best for your child's health and treatment? We have been fortunate in C3 to be able to grow significantly over the last 3 years due to support from the Department of Pediatrics, as well as investment from the UPMC Health Plan, Highmark Whole Care, and PPHN, who have seen the value of complex care and have provided funding for additional staff to really allow us to grow. Here you can see just how much we've grown. So this first graph is patient visits over the last 3 years. It's grown nearly 40%. We look at new patients seen. We are not having to put kids on wait lists anymore. We're not having to turn them away if they meet our criteria. And we've grown 321% in the amount of new patients we've been able to enroll. And then when we look at telehealth visits and becoming more accessible in that way, we've grown by 331%. Another way we've grown is we have started an inpatient consult service. So the structure of that service is primarily that we consult on children who are already enrolled in our program when they are admitted. We have a master patient list of all of our patients, and when we see that they're admitted, we go into their chart and try to identify whether or not they would benefit from our involvement during their admission. You'll see why we can't see every one of them, unfortunately. We also do enroll newly technology-dependent patients, so those NICU grads, kids who otherwise are getting a new trach or G-tube during that admission. And that's really to try to capture that incredibly high-risk time period when they're going home for the first time. Our goals for the inpatient service were fourfold: to ease those transitions from inpatient to outpatient, to provide continuity of care throughout their admission as they move around amongst different units, to provide complex care expertise for primary teams and hopefully make it easier for primary teams to care for these complex patients, and improve parent and patient satisfaction with their care. So what have we accomplished? So for the rest of the talk, the data I will be will refer to pre, which is the year prior to starting the consult service, from 2023 to 2024. And then the post year is that first year of our consult service ending September 29th of this year. I did a chart review looking at number of admissions for our complex care patients, number of distinct patients ever admitted, whether or not they had contact with us within 7 days of discharge, readmission within 7 days, and length of stay. So as I showed you that our program overall has grown tremendously over the last 3 years, that really shows in the inpatient data as well. So in the pre-year, we had 509 total patients enrolled in our program at any point during the year. And that grew to 596 in that next year. Our total admissions grew from 558 to 720, with distinct patients admitted growing from 228 to 290. So nearly half of our patients were admitted at some point during the year. We completed 741 consult visits, and we enrolled 64 new patients via inpatient. We have many of our patients admitted at any given time. So we tracked the census of our patients during the first year of our service, and our average was about 17 patients per day. Our curve follows the same as the overall hospital census, and we had a peak of almost 24 in February of 2025 and a low of 12 in July. Oh, I failed to mention that we only have coverage for 6 half days a week. So each of us typically rounds for a half day and then has other clinical responsibilities for the other half day, which means we definitely cannot see 17 patients a day, unfortunately. So I just want to highlight that in our numbers. If the math is not mathing, that is why. So for our first goal, just to ease transitions and supporting patients from hospital to home. When we look at contact with our office within 7 days of discharge, this could include a portal message, a phone call, or a visit, either telemed or in person. So the gray bar is the year before our consult service existed. The teal bar in the middle is the post year for any kids that we saw them during their admission. And then that last blue bar is those we were not consulted on. So clearly there was a big jump, up by 34%. In the kids that we were consulted on. And I think this reflects a couple of things. I think it reflects that we were proactively reaching out when we know that they're being discharged and they're in a high-risk time. And I also think that it reflects that families knew that we knew what was going on with their admission and felt like reaching out to us was going to get them the help and support that they needed during that time. Readmission within 7 days of discharge did not statistically change over time. And I think, obviously, there are many things affecting readmission rates and length of stay, which we'll get to, but I think it's ultimately a win that our readmission rate did not change despite more kids involved in our clinic and better capturing those newly complex kids that are really high risk of readmission. When we look at those highest risk patients, the new patients enrolled via inpatient consult over the first year of our service, we enrolled a total of 64, and the rate at which this happened really increased over time, which I want to give a special shout out to Tall, our nurse practitioner. I give her credit primarily for this increase because she really did a lot of work with the NICU and making their team aware of how we could serve their patients. And it certainly caught on, as you can see, as the year went on. Our second goal is providing continuity of care within the hospital as patients transition around. So of those 720 total admissions in that first year of our service, 313 of those admissions had an inpatient consult. 161, or a little more than half of all those patients consulted on, had multiple consults. And 113 of them, those multiple consults spanned a transition in care. So that might have been a transition from the ICU to the floor or the CHRU or vice versa. Or it captured a change in calendar week, which reflects a change in the primary team and a loss of continuity there. Length of stay, as I mentioned, there's a lot of factors that go into length of stay, and I hope that we did not cause a higher length of stay by establishing our program, but it was a statistically significant increase. And those we were consulted on were much higher, but I think that reflects that we were prioritizing seeing the more complex kids, and the longer they were here, the more likely we were to have a chance to see them. For example, we generally never see patients who are just admitted for a GJ tube dislodgement unless something goes awry in that admission, and those are the shortest turnover stays. Our third goal was to provide complex care expertise, both of complex patients in general and of the specific patients that we care for. To get at this, I completed a survey of PHM faculty about 9 months into the service to get a sense of how they were perceiving our team. And they are the biggest team that we consult on their patients. And so I wanted to make sure that we were being helpful to them. Unfortunately, we were. So all of them rated us at least moderately helpful or very helpful on a 5-point Likert scale. And all of them reported that on a typical week on service, they have at least one consult for our team. So they are seeing us and finding us helpful, which I'm happy about. When we asked them how specifically we've been helpful, there were a few themes that emerged. So again, assisting in those transitions, taking ownership of advancing feeds, whether in the hospital or saying, it's okay, we can continue advancing these feeds after discharge. Providing the longitudinal continuity for particularly difficult conversations and knowing what the global plan of care is, and a provider confidence in discharging a little bit earlier, knowing that the family is plugged in with us and they have a follow-up already scheduled within the first few days of going home. One provider provided a little bit of a longer story of a patient who was admitted for respiratory failure, ultimately needed a G-tube, which had been an ongoing conversation, and there was disagreement amongst family about how to move forward in that. And they felt that having the continuity providers who could message the importance and kind of know the backstory of all the different feelings involved was really helpful. And I also liked that they pointed out that we're a source of support to families who have trauma related to the hospital. I would venture to guess that all of our patients have some degree of medical trauma. They have been through a lot in this hospital and in other hospitals, and it is a stressful time for them when they're here that can bring up a lot. Another example is for a really prolonged admission for a patient who's here for about 2 months, and we rounded nearly daily with the team, and they felt that that was really helpful at easing transitions, lowering tensions, and providing consistency and trust for that family. Our fourth goal is family and patient satisfaction, and admittedly, the data that I have is the weakest of any of the data so far, and that does not reflect that it is the least important, but I'm just working with what I have. And so I pulled from that same survey of PHM faculty who commented on the ways that they had seen our team benefit families. So they said that C3 has a deep and nuanced knowledge of patients. When we have great relationships and can collaborate with patients and families, the families felt supported by having our team involved. And similarly to the providers feeling reassurance discharging earlier, they also felt that families felt assurance to discharge a little bit earlier, knowing that they had that support from us going home. I had one conversation with a PHM attending several months into our service, and I ran into her in the hall and was asking her thoughts on how things were going. And she conceptualized it in a way that has stuck with me, which was, she's like, sometimes we need your help on the medical management, but a lot of times we have that. What we need is the family to trust that we have that. And so in a sense, like having our team there who they trust to endorse the plan of care really helps everyone feel more comfortable moving forward. So our next steps are to continue to grow and expand our coverage. As I mentioned, we have 17 patients admitted a day, and I would say try, but we do not try to see 17 a day. We try to see as many as we can, but it is nowhere near 17 for just one person. And we also want to work towards optimizing co-rounding. So when it has happened where by happenstance of us arriving at the room at the same time as the primary team, or strategically on particularly challenging or high complexity patients, that has been really well received by both the PHM teams, and we find it incredibly helpful as well, as I think families do too. And so trying to figure out a way that we can optimize that or formalize it, at least for the highest complexity patients. And then providing a patient safety focus. We want to track near misses, med errors, and safety events of CMC to quantify the impact of our involvement in these patients. I have many people to thank for the service. First and foremost, I want to give a shout out to Jackson Valley, who he is the primary other person who rounds on this team. And also he moved to Pittsburgh, was new here, was new to the hospital. And we were like, welcome, you're going to help start this service in 2 months. Hope that sounds good. And he has been nothing but an incredible collaborator on this service. And I have been very grateful for you. Tal Levin DeCanini and Alicia Haupt have also rounded on our team. And the three of them made sure that nothing went awry when I went on maternity leave to get to know this guy this fall. And I was not at all surprised and was very grateful. I want to thank Scott Maurer and Carol May, who didn't think this was the craziest idea ever when I went to them and suggested it. To Justin, you for providing that data and continuing to research our patients. To everyone else on the complex care team, and I am thankful that many of you made it over today. We couldn't do any of what we do without you guys. And then I also want to thank Mary Allenbach and Ryan Collar. They were my mentors from med school at University of Wisconsin, and they started the complex care program there. And not only did they inspire my interest in complex care as a field, but they provided a lot of inspiration and guidance for the model that we started here. Thank you so much for your time.